Hello, students. This is a pharmacology lecture called Drugs for Thyroid Disorders. My name is Jeff. Let's get started. Here are your learning objectives and a recommended reading. We're going to describe the basic physiology of the thyroid gland, including iodide metabolism and hormone synthesis, transport, and metabolism. We're going to compare and contrast the basic and clinical pharmacology of thyroid and antithyroid drugs, paying close attention to levothyroxine, thioamides, and iodine. Thyroid agents to include T4, also known as levothyroxine, and thyroid desiccated. Antithyroid agents include I-131, methimazole, potassium iodide, and propylthiouracil, also known as PTU. We're going to list and describe the drugs known to affect thyroid function and thyroid and antithyroid drugs, and paying close attention to typical drug-drug interactions. We're going to compare and contrast the different clinical situations that necessitate treatment with thyroid and antithyroid drugs, to include hypothyroidism, hyperthyroidism, specifically Graves' disease, and thyroid storm. Here is a drug list to include thyroid agents listed here and antithyroid agents listed here. A brief summary of the drugs used in thyroid disease is here. In hypothyroidism, in the absence of a thyroid gland or in the absence of thyroid gland function, we can administer levothyroxine, which is T4, liothyronine, which is T3. In the case of hyperthyroidism, when the thyroid gland produces too much thyroid hormone, we can use thioamides, specifically propylthiouracil. We can use iodide, and we can use beta blockers or I-131. There is a high-yield handout and notes packet. There's a high-yield handout posted in Canvas that is a notes packet derived from Katzung and Trevor's Pharmacology, Chapter 38, to include a drug list, figures, and additional granular information that'll help you understand drugs for thyroid disorder. At the Osmosis site, I've created a playlist for you called Dr. Staudinger Thyroid Video Playlist. So if you click on this link, the playlist will be revealed to you. This is a supplemental learning resource that should aid in your board prep activity. Very high yield material. There are embedded quizzes, so if you click this button, quiz all, choose what level or even flashcards or CME. I choose level 2. There are 21 questions and it's timed. This is excellent material that I've been through and found very helpful. Also, for your board exam preparation, there are 2 evidence-based medicine links for your perusal. If you click on this link, the article entitled Why Propranolol is Preferred to Other Beta Blockers in Thyrotoxicosis or Thyroid Storm will be revealed to you. If you click on the second link, an article entitled The Mechanism for Amiodarone-Induced Hyperthyroidism and Clinical Implications will be revealed to you. I provide here a Mayo Clinic case study entitled Thyroid Storm, a case study from the endocrine teaching clinics. And if you click on this link, a very interesting case study will be revealed to you. This will give you a much more granular level of detail and information for your board preparation material. The specific beta blocker propranolol is used in thyrotoxicosis, also called thyroid storm or symptomatic hyperthyroidism. This drug is widely used to reduce heart rate and tremor during thyroid storm. This drug inhibits conversion of T4 to the more biologically active hormone T3 and also may help reverse reduced systemic vascular resistance that occurs during thyroid storm. Released thyroxine, also known as T4, is converted to the active and potent thyroid hormone T3. That conversion takes place through monodeiodinase enzymes, to include type 1 and type 2. There's also a type 3 monodeiodinase, which converts T4 to reverse T3, which is inactive. Again, T3 is the very active and potent form of thyroid hormone, whereas T4 and reverse T3 are not as active. In thyroid storm, an excess of T3 is produced that manifests in cardiovascular symptoms, to include tremors, shakes, increases in pulse and blood pressure. In other words, thyroid storm. That is the biology of thyroid hormone. Again, T4 is released from our thyroid gland and circulates in our system, and the conversion takes place through these enzymes when appropriate to produce T3 or reverse T3. The drug propranolol works at two levels. By inhibiting type 1 and type 2 monodeiodinase, this drug prevents the conversion of T4 to T3. In addition, propranolol inhibits the cardiovascular symptoms produced. So propranolol works at two levels. That is why propranolol is the preferred drug over other beta blockers in thyrotoxicosis and thyroid storm. Here is a pictorial representation of the thyroid gland. The isthmus is that part of the thyroid gland which connects the two lobes. Let's talk about thyrotropin, aka thyroid stimulating hormone, TSH for short. TSH is released from the pituitary gland and stimulates the thyroid gland to produce T3 and T4. In the periphery, T4 is converted to T3, and then there's a feedback regulation. When concentrations increase of T3, there's a negative effect on the production of TSH in the pituitary. Moreover, increased levels of T3 in serum stimulate the hypothalamus to stop producing thyroid-releasing hormone, which is the primary signal to the pituitary. So you can see the hypothalamic pituitary axis that regulates TSH and T4 and T3 secretion and conversion in the periphery to T3. So TSH is high in primary hypothyroidism, and TSH is the most sensitive screening test for both hyper and hypothyroidism. If TSH is within the normal range, this excludes these two diagnoses. The thyroid hormone receptor comes in two flavors, alpha and beta, and is activated by thyroid hormones, and it's a member of the nuclear receptor superfamily of ligand-activated transcription factors, all listed here. There's glucocorticoid receptor, mineralocorticoid receptor, progesterone receptor, androgen, estrogen receptor, retinoic acid receptor, thyroid hormone receptor, vitamin D receptor. All of these receptors have a conserved overall structure in which they have a zinc finger DNA binding domain, surrounded by a ligand binding domain and two activation function domains. So these are ligand activated transcription factors. On the left is the name of the receptors. On the right side is what they're activated by. This is a very powerful superfamily of ligand-activated transcription factors that regulates all kinds of interesting biochemistry and biology in our bodies, and humans have 48 nuclear receptors in our bodies. And here's a diagram of how nuclear receptor signaling works. A small lipophilic ligand traverses the cell membrane to bind to its cognate receptor. In our case, we're talking about thyroid hormone as the ligand, T3, binding the thyroid hormone receptor. That complex then shifts the conformation. You can see the circle becomes a square and binds to its cognate response elements in the target genes that it regulates in those tissues to regulate gene expression. That's what this stair step is all about. Here's the structure of the thyroid hormone. There's also structure of other hormones shown here. To delve into the biochemistry and molecular biology of thyroid hormone action, the name of the game here is gene activation. In the absence of hormone, there's target gene repression through thyroid hormone in a complex with retinoid X receptor to recruit histone deacetylases that actively repress gene expression. Upon the addition of thyroid hormone or levothyroxine drug, you see gene activation through the release of co-repressor proteins and the recruitment of co-activator proteins and histone acetyltransferase enzymes. Together, the receptor regulates target gene activation in those tissues where the complex is expressed. Very briefly, from a physiological standpoint, thyrotropin-releasing hormone is released from the hypothalamus to stimulate the pituitary gland to produce thyroid-stimulating hormone, TSH. This signals the thyroid gland to produce T3 and T4 hormones, which regulate increased metabolism, growth and development, and increased catecholamine effects. In a negative feedback loop, this increase in thyroid hormone production produces a negative feedback effect on the anterior pituitary gland to decrease TRH. Thus, a balance is achieved. And for those organic chemistry enthusiasts in the audience, here are the structures again of T4, T3, and reverse T3. The green balls indicate where the iodine group is located on each of these hormones. Thyroid hormone synthesis takes place entirely within the thyroid follicle and relies on the actions of a protein called thyroglobulin. The tyrosine residues of thyroglobulin that become iodinated to produce conjugated thyroglobulin that is endocytosed back into the follicular cell, and through a proteolytic reaction, T4 and T3 are produced and released into the blood. In this figure, the sites of action of various drugs that interfere with thyroid hormone biosynthesis are shown. Here are the symbols listed in this figure. Iodide is taken up through a transmembrane transporter where peroxidase converts it to iodine, which is oxygenated iodide. Following oxygenation, iodine is integrated into the tyrosine residues of the protein thyroglobulin. Iodides and thioamides inhibit the conversion of iodine and the integration into the thyroglobulin molecule. Iodides also inhibit the proteolytic reaction that releases T4 and T3 into the blood. In the peripheral tissues, T4 is converted to T3, and beta blockers, corticosteroids, and amiodarone inhibit that conversion. And it turns out radiocontrast media also has an inhibitory effect on the conversion of T4 to T3 in peripheral tissues, something to be aware of. Now, thiocyanate and perchlorate are environmental contaminants that themselves inhibit the uptake of iodide and all subsequent downstream steps. Also something to be aware of. If you click on this link, the article describing the mechanism for amiodarone-induced hyperthyroidism and its clinical implications will be revealed to you. Amiodarone is in the antiarrhythmic class of drugs. It's used to treat ventricular arrhythmias, atrial fibrillation, and also used in the prevention of VTs in high-risk patients. Amiodarone can cause type 2 induced thyroid toxicosis. This occurs from its ability to actually destroy thyroid tissue. Hence, patients started on amiodarone need a baseline measure of TSH, free T3, and T4, and a repeat test every 6 to 12 months to look for the emergence of symptoms of hyperthyroidism. Because amiodarone is a commonly prescribed medication, each 200 milligram tablet contains 74 milligrams of iodine, and 10% of that is released every day as free iodine. The daily recommended dose of iodine intake for adults is 0.15 milligram. Thus, 50-fold higher levels are released when patients are taking this medication, and that becomes toxic, and leading to the increased thyroid hormone production and release seen in amiodarone-induced thyroid toxicosis. Among the thyroid agents, I'm going to focus on levothyroxine, also called L-thyroxine. This drug is used to treat thyroid hormone deficiency. It is the manufactured form of the thyroid hormone, comes in the form of thyroxine, T4. As we talked about previously, T4 is converted to T3 or triiodothyronine. The maximum effect of this drug can take up to 6 weeks, and there are numerous side effects from excessive dosing listed here. Dosing is based on regular measurements of thyroid stimulating hormone and T4 levels in the patient's blood. Important for clinicians to understand that numerous drugs impair levothyroxine absorption, to include antacids, iron, as well as sucralfate, which is an anti-ulcer medication, cholestyramine, orlistat, and proton pump inhibitors. Let's talk about the thioamide group of medications. Thioamides include propylthiouracil, PTU, methimazole, and carbimazole. Carbimazole is converted to methimazole, and methimazole is 10 times more potent than PTU. You can see their structure here. Methimazole is used to treat Graves' disease in hyperthyroidism. That's when the thyroid gland produces excess thyroid hormone. This group of medications blocks iodide organification and has major side effects, to include agranulocytosis, leukopenia, thrombocytopenia, aplastic anemia, and liver inflammation. Clinicians should look for elevations in serum transaminases, jaundice, fulminant hepatitis, hepatic necrosis, encephalopathy, and death. Therapy with thioamide derivatives should be administered cautiously in patients with pre-existing liver disease and a history of alcohol abuse or hepatitis. Methimazole is taken before thyroid surgery. This lowers thyroid hormone levels and minimizes the effects of thyroid manipulation, such as thyroidectomy. Methimazole inhibits the enzyme thioperoxidase. This catalyzes a necessary step in the synthesis of T3 and T4. You can see that here. Thyroid peroxidase attaches iodines to the tyrosine residues in thyroglobulin proteins, key in the production of thyroxine and thyroid hormones. Let's talk about PTU, propylthiouracil, and its indications for usage. This drug is indicated in patients with Graves' disease, and in patients with toxic multinodular goiter. Some of your patients will be intolerant of methimazole, necessitating use of PTU. This drug is also used in surgery or where radioactive iodine therapy is not an appropriate treatment option, such as in pregnant women. It's used to ameliorate symptoms of hyperthyroidism, and it's used in preparation for thyroidectomy. It's also used in radioactive iodine therapy in patients who are intolerant of methimazole. This drug inhibits the synthesis of thyroid hormones and inhibits the conversion of thyroxine to triiodothyronine in peripheral tissues. It does not inactivate pre-existing T4 and T3. Incidentally, T4 and T3 are stored in the thyroid or are found circulating in the blood. This drug does not interfere with the effectiveness of thyroid hormones given by mouth or by injection, and may be an effective treatment for thyroid storm. Potassium iodide is a stable form of iodine. When given to your patients, this blocks iodine uptake. It's used to treat certain overactive thyroid conditions. It's used as a treatment for iodine deficiency. It's also used in conjunction with antithyroid medicines to prepare the thyroid gland for surgical removal. Potassium iodide can also be used to protect the thyroid from radiation exposure. Potassium iodide will shrink thyroid glands in your patients, decrease thyroid hormone production, and does not affect the heart rate and does not produce an irregular heartbeat. Radioactive iodine, I-131, is used as a therapy in the treatment of thyroid cancer. The thyroid gland absorbs radioactive iodine through the uptake transporter. The radiation destroys the thyroid gland and the cancer cells and has little effect on the rest of the body. This therapy is contraindicated in pregnant women as a Category D drug. Let's talk about beta blockers for use in hyperthyroidism and during thyroid storm. There are 3 primary drugs in this category: propranolol, metropropol, and atenolol, which has less cerebral effects. Propranolol is the most widely studied and used in thyrotoxicosis or thyroid storm. This drug produces clinical improvement of hyperthyroid activity and does not alter thyroid hormone levels. Their mechanism of action includes membrane stabilizing action and inhibits T4 to T3 conversion. This ameliorates many disturbing symptoms and side effects of hyperthyroidism and thyroid storm, and it's also secondary to increased catecholamines due to blockage of beta receptors, again indicated in Graves' disease and thyroid storm. Perchlorate is a competitive inhibitor of iodide uptake, competes with and blocks the sodium iodide symporter. Perchlorate has no effect on the iodination process itself. Perchlorate is used as a means of controlling amiodarone-induced thyroid dysfunction. There's a high-yield handout posted in Canvas that is a notes packet derived from Katzung and Trevor's Pharmacology, Chapter 38. Students, there's a series of practice questions at the end of this PDF, as well as an additional series of practice questions on the Canvas page. Please take advantage of these practice questions, as well as the Osmosis video playlist and practice questions I've prepared for you. At the Osmosis site, I've created a playlist for you called Dr. Staudenger's Thyroid Video Playlist. Endeavor to persevere.